Okay, welcome to part 2 for the review of Chapter 35, Geriatric Emergencies. Okay, so we ended up leaving off there. Let's go with the scene size up. You're there to evaluate the patient. Geriatric patients are more commonly found in their homes, retirement homes, or skilled nursing facilities. Many older people do live by themselves, and they may be hampered if their condition prevents them from getting to the door. Take note of any negative or unsafe conditions in the house and report them to the elderly. Remember, when you're doing your scene size up consists of 5 things: scene safety, BSI, number of patients, MOI, NOI. Is it a mechanism of an injury or nature of illness? Do you want to consider additional resource? If so, who? Do you need ALS on scene? Do you need firefighters for manpower? Or do you need police on scene? And the 5th one is, do you need to consider C-spine stabilization if it's a trauma patient? Okay, those are your 5 things for scene size up. After that, you go to your primary assessment. You verbalize your general impression of the patient. You determine the level of consciousness. You do so by AVPU, the OVPU, and the ALC times 4. Are they alert, oriented, and conscious? To person, place, time, and event. Do they know who they are? Do they know their first and last name? That's person. Place. Do they know where they are? Do they think they're a little boy living at home with mom and dad when they're actually in a retirement center and they're 86 years old? That's person, place. That's place. Time. Do they know not what time, not is it 10 o'clock in the morning, is it 5 o'clock at night? No. Do they know what day of the week it is? Do they know it's morning, afternoon, or night? Do they know what month it is? Okay? Person, place, time, and event. What was going on before they called you? What happened that made them call you? Were they out raking the leaves during the fall, and they have hay fever, and they have allergies, and they're in a metered dose inhaler, and now they're complaining of difficulty breathing, chest pain, chest discomfort? That could be associated with. So person, place, time, and event. What were they doing before you showed up? What called them? Okay? After that, you're going to do your ABCs. Airway, breathing, circulation. Are they breathing? Yes or no? Are they breathing too low or too slow? You all know what the respiration rate is for a normal, healthy adult. Okay, that's airway. Is it secure? If it's not secure, secure. OPA, NPA, head tilt, chin lift, modified jaw thrust. Breathing. Are they breathing sufficiently to support life? Too slow, too fast? If they are or they aren't, what do? Do you use oxygen or not? If you give them oxygen therapy, do you use a nasal cannula, non-rebreather, or do you breathe through them with a BVM and high-flow oxygen? Okay, circulation. Check their circulation. Check their pulse. You know what the pulse is supposed to be for a normal, healthy adult. Okay? What do you do when you check your pulse? You check at the radial. What are you touching when you check the radial pulse? You're touching the skin. The skin is the largest organ in the human body. You're going to check for skin color, temperature, condition. If it's cool and clammy on a warm summer day and it's cool and clammy, they're probably going into shock. What kind of shock could they be going into? Could they have an internal bleed, hypovolemic shock? Do they have an infection? Could they, systemic? Okay? What is it? So that's what we got to try to figure it out. Okay? So after you do your AB, and then you make your transport decision. Is this a stay and play or scoop and screw? The person's not feeling that well. I don't see a life threat, so I can take a few extra minutes, ask them all the questions I want to do, that I want to ask them during my OPQRST or sample history, which is our history, which is the next section. Or this person's life's in danger. I need to stabilize them, get them to the hospital as quickly as I possibly can. Okay? So that's your primary assessment. Then you do your history taking, sample, signs and symptoms, allergies, medications, passport, medical history, last organ taking events leading up to, and your OPQRST, onset, provocation, quality, radiation, severity, and time. After that, you move to your secondary assessment. For a medical patient, the secondary assessment is you're going to concentrate on the affected body part or the body system. And there's 8 things you need to check. What are those 8 things that you need to check when you evaluate a geriatric patient? Well, off the top of my head, and with the help of my little cheat sheet here, you've got your cardiovascular, you've got your pulmonary, you've got your neurological, your musculoskeletal, you got the reproductive, you got the psychological, you got the GI, and you got the integumentary, which is the skin. Okay? Those are the 8 things you need to know when you're evaluating a medical patient. Now, the first 11 steps in a medical patient or a trauma patient, the first 11 steps are exactly the same. Okay? It's when you get down halfway, it's when you get to the history, is when you get done with your ABCs, you make a transport decision. That's where it changes for a medical or trauma patient. Okay, trauma, you go step A, step B, step C. It's lined out. You got to do this and that before you do that. Medical patient, you got to do this and that. But medical patient, you get to play detective with medical patient. You got to ask them a lot more questions, try to figure out. That's when you really use a lot more of your knowledge of the human body and such. So look for your life threats. Determine the transport priority. Okay. And let's see. Make sure you take your vital signs. After you're done with your secondary assessment, what's next? Vital signs. Blood pressure, pulse, respirations. Okay, and you know what the normal healthy blood pressure is for a healthy adult? 120 over 80. Is it too low? Why? Is it too high? Why? What's their medical history? Could that be related to what's going on, why their blood pressure is too high? Okay, pulse. You know what the normal pulse is for a healthy adult. Is it too slow? Why? Is it too fast? Why? What's going on? What's the domino effect when somebody's pulse is going too high? Okay, respirations. Are they breathing at 12 to 20 times a minute? Are they too slow? Are they too high? You know, there's an old saying, it says 8 to 28. If they're less than 8 or over 28, we ventilate. If they're breathing 8 or less times a minute, then we have to ventilate with them with the BVM high flow O2, 15 liters per minute, and the saturation on that is 90 to 100%. Okay, they're breathing 90 to 100% oxygen. If they're breathing too fast, over 20 times a minute or more, you got to ventilate for them as well. Try to slow it down. Want to increase that perfusion, increase that diffusion that's going on in the lungs, increase the perfusion that's going on throughout the body. Okay? Then you reassess the patient. If you have a stable patient, you reassess the patient every 15 minutes. You can do it every 10 minutes if you want to, but if it's an unstable patient, you want to keep an eye on that patient. You don't sit on the jump seat behind the patient. You sit on the bench seat. You never take your eye off the patient, because things can change very quickly, no matter the age of the patient. You recheck a patient's vital signs every 5 minutes. You should have, at the bare minimum, 2 sets of vital signs before you arrive on scene at the hospital, because you want to see if there's any trending taking place. Trending refers to when vitals change. Is the blood pressure, pulse, respiration going down, or is it going up? Okay, you want to see if there's any trending. The doctors want to know. If you tell them that it's trending and you're able to get maybe 3 sets, maybe 4 sets of vital, if you have a long transport to the hospital and you see some trending, you can document it. You can see where it started, and let's say the BP is going down. You can document how quickly it's going down, or how slowly it's going down, and that'll help give the doctors that'll point them in a different direction of how they want to treat the patient. The more information you give the people at the hospital, the nurses, the charge nurse, trauma nurse, or the doctor, the more information you give them when you arrive at the hospital, makes you look good, shows that you did a very thorough investigation, evaluation of your patient, as well as giving a good report. And it makes the ability of them to give good patient care even better. Okay? Let's see. Trauma in geriatric patients is very, very important. Their bodies break much easier, they bruise much easier, and it takes them a lot longer to heal. So keep that in mind. An older pedestrian, an older person, a geriatric patient, is much more likely to have a life-threatening complications after being struck by a vehicle than a younger person, because their bodies can't take it as much. Okay? They have a higher mortality from penetrating traumas. They tend to fall a lot. They have broken bones more frequently because their bone density changes. Their bones are not as strong as they used to be. They have osteoporosis. They tend to have hip fractures much more. You have a hip fracture when you're an elderly patient. You tend to have more internal bleeding because it's very vascular down there. Got a lot of the bones down there are very big. A lot of bone bleeds. Environmental injuries. They're very susceptible to overheating or getting too cold. Hyperthermia or hypothermia. So you got to keep an eye on that. And when in doubt, rapid transport to the hospital. Keep an eye on treating for shock, because we know what shock is. Shock is inadequate tissue perfusion. So if they're getting inadequate tissue perfusion, then their pulmonary system is being affected as well. So always keep an eye on that. Let me see here. What else? You know with the elderly that they're going to have advanced directives, DNRs, DNIs, DNH. A DNR is do not resuscitate, a DNI is do not intubate, and a DNH is do not hospitalize. It's a legal document that the patient and the patient's doctor both discussed and reviewed. And the DNH is do not hospitalize is they do not want to go to the hospital. They live in an assisted living center, they're having difficulty breathing, they don't want to go to the hospital. So the nursing home and assisted living center is supposed to respect that. DNR is the most common one you're going to run into as an EMT. do not resuscitate. You're going to show up at a nursing home or their house or an assisted living center, and they're in the middle of having a heart attack, or they're getting ready to have a heart attack, and you show up and the nurse tells you, oh, they've got a DNR. Okay, well, that means that you can't do chest compressions. You can give them oxygen, you can put them in a position of comfort and make them comfortable, but you can't do chest compressions. Okay? In order to honor that, you have to see the DNR, you have to hold it in your hand, and you have to make sure that it's valid. It has to be dated, it has to have the patient's signature and the doctor's signature. If it's missing one of those two signatures, it is not a valid order, and you have to go give CPR, whether you like it or not. It's an invalid order because it's not a complete legal document. A DNR is a legal document. If the patient is unable to sign, then usually the POA, the power of attorney, for that patient will sign in place of the patient, but the power of attorney papers need to be accompanied with the DNR so you can verify that Joe Smith, who signed in the patient's name and put power of attorney next to it, that you actually have the pieces of paper right there that you can flip through very quickly to verify, yes, Joe Smith is the assigned power of attorney for this patient. Just don't take somebody's word for it. You need to hold it in your hand. If for some reason the patient wants to go to the hospital, the patient has to destroy the document right in front of you. They have to rip it in front of you. They have to tear it in front of you. Or the power of attorney has to do that in front of you. They can't come to you and say, here, it's ripped in half. I ripped it up and down. I'm sorry, that could have been done a month ago. I had to see you rip it in half. I had to see you destroy it. Okay? When in doubt, you're not quite sure what you got to do, call med control. Tell them what you got. Tell them what the situation is. Okay? Let the doctor make the call. Okay? DNI, do not intubate. DNR, do not resuscitate. DNH, do not hospitalize. They have to be legal documents. All signatures need to be present or it's not valid. You're going to have things where you're going to have elderly abuse. Either mentally or physically, they can be abused. Nobody should ever be abused. If at any point in time when you're evaluating a patient, if you think that they have been physically or emotionally abused, you are legally obligated to notify the authorities so that an investigation can take place and to determine if the environment or if any individuals at that person's place of employment or where the patient lives is guilty of doing such, and then let the authorities take the normal course of action. You could be wrong, and it could not be elderly abuse, but we have a responsibility that if we foresee it and we think it might be, let the doctors and nurses know at the hospital. You don't have to call the police officers and get them on scene, make a big hoo-ha out of it. Whenever you report any type of animal abuse, child abuse, elderly abuse, it's always done with nobody knowing that you are the one who reported it. Everything is kept quiet. Nobody gets your name. And that's it. And I think that's about it for this chapter. Chapter 35. I apologize. I've taken up a lot of time of the class. I'm not going to have enough time to review the other chapter with this class, but I will create a video for that, and I'll get that taken care of for you guys so that you can see it. Okie doke. So everybody stay healthy. Take care of yourselves. Take care of your family. We will all get through this. It's going to take some time. It's going to take weeks and months to get through it, but we will get through it. Use your common sense. Don't go in a crowd. Stay home if you have to. Keep yourself healthy, hydrated. Eat food. Don't let your body get run down because then you're susceptible to getting the flu. You don't want to get that right now. And other than that, study hard, have fun, and it's been my pleasure. I hope I've been able to teach you something or help you understand something. You guys take care and have a great day. Take care. Bye-bye.